The leaders from the CHOC Sharon Disney Lund Medical Intelligence and Innovation Institute, the Medical Intelligence Society, and the American Board of Artificial Intelligence in Medicine invited Diya Health to present its all AI-based interpretation platform that is regarded as safe for medicine. Here's the founder of Diya, Amit Bansal's presentation to this group of AI leaders in medicine from around the globe.
Bob, Deborah, and team, thank you so much for inviting us. We're grateful to you. So with that said, my name is Amit Bansal. I'm the CEO and founder of Diya Health, and we're here piggybacking on Bob's idea of using AI for scribing. Here, we're going to talk about using AI for interpreter. We've rolled out the first AI interpreter as far as we know in the market. And the more important part for us is how do we make it safe? How do we make AI safe in healthcare? And that's what we're going to talk about. From an agenda standpoint, I'll start out by giving a very quick story on Diya, on why we started it, then share a rationale for why building an AI interpreter was worthwhile for us, share some of the challenges we faced, and then finally how we succeeded at putting an AI interpreter in a clinician, including nurses' pockets, as well as some of the other folks, and while keeping it safe in healthcare. So with that, let me just dive right into the personal story. My dad had lived in the US before moving back to India, 20 plus odd years in the US, 20 some odd years in India. And then when he suffered a stroke in 2017, the physicians were actually living, some of the physicians were in the US and some of them were in India. And we had to pull together a team from two countries, as well as many of the family members. And many of our relatives are physicians too, that needed to come together to help take care of Dad. I was the one to take the lead on this, providing communication for everyone involved. And let me tell you, it was a murderous task. Luckily my dad did well, but in it, I learned that communication between patients, providers, family in a disjointed care delivery model was something in a way of a problem we wanted to solve as a group of engineers and doctors. So we wanted to ensure all the things that one would imagine, from scalability all the way to HIPAA compliant, would be met with our solution, which is what, we started to do. In terms of the development, we were founded in 2018. For the first 4 years, we built a very robust communication platform that brings clinicians, patients, and families together. We rolled it out in India and then at Mount Sinai and some of the other health systems integrated with EMR. And by 2023 onwards, we saw that AI was mature enough that we could leverage it for providing both interpretation and translation services. And that's what we did. These were some of the impacts that we were able to have, from care transitions all the way to translations and improving capacity and compliance, what have you. And the experts from some of these health systems were responsible for helping us along the way. With that, let me dive into the AI platform for this conversation while we're here. In terms of a current solution, in most cases, an interpreter relies on a human interpreter, as you can see on this screen here on the other side. Usually there's a provider, there's a patient, and interpreter is someone, whether that person may be sitting in person or maybe on a call. And so the first question is, why build it with AI? And the answer that we found was that interpretation was needed through the continuum of care. From pre-authorization, scheduling, intake, physician visits, labs, specialists, revenue cycle management, we needed interpretation across the field. And on top of that, what the patient population that needed interpretation was growing, and so were the languages that they needed. I'll share some examples towards the end if there are questions about that. And what we found was there just weren't enough interpreters to serve the need as the need is growing. Cost, quality, and consistency were a factor. So AI, we felt, was something that could bridge that gap with quality and do it, yes, indeed, at a much lower cost than what we saw otherwise happening. In terms of how is it different from ChatGPT or Google Translate? I mean, that's a fair question that comes up for us often. So in healthcare in particular, interpretation services cannot be a standalone solution. We had to have a robust communication platform, which, by the way, we'd built already. In the EMR integrations, we had communication services, we had single sign-on, integration with content vendors, along with clinical workflow from the ICU to the emergency department or to home health or the outpatient clinic. We had these solutions that we'd built over the 4 years. And then what we did was we brought in Azure AI speech services, including Whisper AI, speech recognition, speech synthesis, and added AI translations to it. So you could think of the Diya team less as an AI experts, but more as an aggregator for bringing together AI innovations in a way that helps clinicians and brings it to the doorstep of medicine. Moving right along, in terms of challenges, and there were many. And I'm not saying that we're done dealing with challenges, but the first one is the most one that troubled us more, is that as you look at the interpreter is actually watching the patient and the family member and the physician. Whereas in building the first interpreter, we knew it had to sit on a clinician's phone. And that's what we had. So in an interpreter that we built, it was in essence a blind interpreter. So imagine a blind interpreter trying to figure out who is speaking at any given time, what language is that person speaking, what is the context of their speech, whether it's a revenue cycle manager related conversation or a clinician or a specialist and what have you. And then there are pauses in speech. We end up misspeaking. There are overlaps in speaking. Sometimes the patient didn't hear the clinician or clinician didn't hear. So all of the things that the human picks up by looking at the patient and the clinician, we had to determine by just listening and providing. And then a single interface, a phone has a single interface. You know, Dr. Hoyt talked about the training time for a clinician. We needed to make sure that anyone can grab the phone and start using it almost instantly. And we, for the most part, succeeded with it. There were processing time delays. The messages needed to be sent to various servers that needed to interact. There were workflow design issues of different people using throughout the continuum of care, how they were using it. And then there is future proofing. Today, Azure seems to be one of the leaders with ChatGPT. Tomorrow, Google or NVIDIA may be the leaders. We needed to make this a pluggable technology. So looking then right into the solution, we saw that the interpreters are either in person, talking to the patient and doctor at the same time, or it's in a telehealth mode. And we wanted to provide a solution for both of them. So let's look at in terms of the first solution, which is the in-person solution. In the in-person solution, I'd like for you to look at just 3 parts of it. The first one is the bottom part, where the clinician is using their own phone and talking to the patient. And that phone is actually running the interpreter on it. On each side of this yellow box, there are the Azure speech services and Azure translation services. And then in the middle, the recognition of the speaker, the recognition of the language that is being spoken each time, converting speech to text, and then taking that text and converting it to the translated text, and then creating the synthesized voice so that then that can be sent back to the interpreter is something that we developed in the in-person mode. And I'll come back and take questions in a second, but I just want to give you a quick overview of then with the telehealth mode, what the first thing we were able to do is add more people. So in addition to clinician and patients, you can add more family members, you can add more specialists or nursing staff or respite care workers. So they could all take part in that communication and each one had their phone. The second thing we added was the interpretation needed to work with a telecommunication technology, which included text, audio, video, something we'd already built, but here it came in handy again for the telehealth services. In terms of what telehealth allowed us to do from a simplification standpoint is we were able to figure out who the speaker is without without each time trying to recognize the voice. So it saved us on an efficiency standpoint because they had done a multi-factor authentication. So we knew who the speakers were and we knew what language they were going to be speaking. That allowed us to do some time savings or performance saving gains we were able to make. In addition to that, we had to do some of the automation around muting others when somebody's talking, provide some interfaces so they could talk to one another if they needed to. And in terms of major benefits, the connecting more people, and what we found was in some cases, the family member may be more fluent in yet a third or a fourth language. So family member could actually listen in on a different language than that was being spoken by the patient or the clinician. So just some additional benefits in addition to being a little bit better performance is what we were able to get. And I'm almost done with my presentation, probably in another 30 seconds or so. From a risk mitigation standpoint, how do we make AI safe for healthcare? The first thing we had to do was adhere to the multiple requirements that human interpreters have to comply with, that our AI platform had to comply with that. And the second thing we did was we provided a transcript. In standard mode, there's a transcript of what the clinician said, what the patient said, what the interpreter said. And at the end of every conversation, we provided that transcript so the clinician could review it and make sure that the communication was one that was intended and nothing different. In addition to that, we added an enhanced accuracy validation, an EAV mode in which the clinician could see the closed captions of what was being spoken, as well as the subtitles of what the interpreter is saying or what the patient is saying. So in real-time mode, the clinician could then see what is being said. So here you're looking at a standard mode, which actually has a transcript in the clinician's language, also supports the language of the patient and anybody else, but also in an enhanced mode where the subtitles and closed captions can be seen. Finally, in the adoption customer acceptance arena, leveling the playing field for the limited English proficiency population was an important communication gap that we set out to achieve. And we've done it in many areas by putting the interpreter in the coat pocket of the nurses, doctors, front office staff. In terms of we're still working through who the ideal customers are, where the adoption might be, whether they want EMR integration to start with, or the need is so high that they want to get started right away, single sign-on, some of the other things. But it's a journey, and maybe next month or in some time in the future, I can come back and talk about some of the data that we've collected along the way. But at this point, I will be happy to take any questions.
Thank you for watching. Contact Diya Health to learn more.